Welcome to Orthodontics 101. My name is Madeline Goodman, and I'm an orthodontist in Potomac, Maryland. And I work together with Jennifer Triandafalou. I've worked with her for many years, and she's really opened my eyes to the world of myofunctional therapy, which is something that I never had the opportunity to learn about in school. And I've really seen firsthand how great an adjunct myofunctional therapy is to the treatment of my patients. So I'm very excited for you to be starting your journey towards becoming one with her at her course. So I thought it would be valuable to you to go over today some basics in terms of orthodontic treatment planning and diagnosis, so that when you start looking into patients' mouths, you're a bit more familiar with the way orthodontic appliances look and the way teeth should fit together, and also so that you can better communicate with the dental professionals that you'll be working with. So first, to review a little bit of terminology, the upper jaw is called the maxilla, and the lower jaw is called the mandible. So when we talk about the upper teeth, we call them the maxillary teeth. Those are the upper teeth. And the lower teeth are, the technical term for them is the mandibular teeth. So just to review also that certain types of teeth, the front four teeth are called incisors. The two in the middle are central incisors. The two on either side are the lateral incisors. The canine teeth are the pointy teeth on the sides of the incisors. Then you have two premolars and three molars. And the third molar in the back, that's the wisdom tooth, and most people don't have room for those in their mouth. So most people will have two molars on each side. And then, of course, you have the palate. So here's some photographs of what I consider to be a normal mixed dentition. So by the time a child is anywhere between 7 to 9 years old, they should have their 6-year-old permanent molars in the back. And then these are baby molar, baby canine, and then the 4 front permanent incisors. So by the time a child is about 8 years old, they will have lost the 4 front baby teeth and gained the 4 front permanent teeth. And the 6-year molars erupt behind the baby teeth. So they don't push out any baby teeth, they erupt behind. Whoa. Sorry. Okay, sorry about that. I skipped a slide. All right, so here is a normal adult dentition. So by the time a child is about 13 years old, they will have lost all of the baby teeth and all of the permanent teeth will have erupted. So in this case, this is sort of an ideal bite. And in an ideal bite, the upper teeth fit over the lower teeth like the lid of a box. And this is important that all the upper teeth are fitting kind of in close relationship on the outside of the lower teeth, because this allows the forces that are generated when someone is chewing or grinding their teeth or doing the daily life activities, it evenly distributes the forces throughout the mouth and the joints. And this is ideal for the health of the teeth and also the musculature in the mouth. So this is why in orthodontics, our goal usually is to achieve a bite like this for the longevity and health of the actual teeth and the joints. So most people do not present with teeth that look like this. They usually present with a malocclusion. And a malocclusion is when the teeth do not fit together properly. And there's different ways that we know that the teeth are not fitting together properly. And one dimension that we look for first is the vertical dimension. And in doing so, we evaluate the anterior teeth. So this is what we call a deep bite or an overbite. So ideally, when you think about that lid of a box, the upper teeth should only overlap the lower teeth by a couple of millimeters. And in a deep bite or overbite, they overlap more than a couple millimeters, and sometimes, as in this case, almost all of the way, so you don't see any lower teeth. Conversely, there's something called an anterior open bite, and that's when the upper teeth don't overlap the lower teeth at all. And actually, as in this case, you see space between the upper and lower teeth. This is not great long term because when the person is biting down, the back teeth are taking all of the force of the biting. So over time, the back teeth can wear down, they can break, and it's also not a great situation for the musculature of the face. So the next dimension we want to look at is the transverse dimension, or the width of the jaws. And this is something that we see quite commonly, and it's called a crossbite. And that's when an upper tooth or upper teeth are sitting inside the lower teeth. And this happens because the upper jaw is narrow in comparison to the lower jaw. So in order to find a comfortable way for the teeth to fit together, the patient will shift their lower jaw to one side. And in this case, in this picture, the person is shifting their lower jaw to the right. So this is a mirror shot. So they're shifting their jaw to the right, and it's creating this crossbite. So we no longer have the lid over the box. We have the lower teeth sitting outside the upper teeth. So the next thing we're going to talk about is spacing. So when there are baby teeth still present in the patient's mouth, it's normal to have spacing. And I just wanted to draw attention to this term. It's called a diastema. That's when there's a space between the front teeth. We call that a diastema. So when their baby teeth are not present anymore and it's only adult teeth, it's really not normal to see a lot of spacing. And this can be a sign that there's something underlying going on, such as a tongue thrust, which you'll hear a lot about this weekend. But a lot of times when we see spacing between the teeth, it's often accompanied by flared upper and lower anterior teeth. Flared means that the teeth are kind of tipped forward over the bone in the front. Okay, so the next dimension we want to look at when we're looking for a malocclusion is the anterior posterior dimension, or the front to back bite. So this is considered an ideal bite, a class 1 occlusion, and we're going to go through each of the 3 classes of malocclusion. So class 1 is when the upper teeth, again, you have that lid of a box and all the teeth on the sides are sort of meshed together. A class 2 malocclusion, or what we consider colloquially as an overbite, is when the upper teeth are ahead of the lower teeth and the upper jaw is ahead of the lower jaw. And you don't see that nice meshing together of the teeth on the sides. So here is an example of a patient with a class 2 malocclusion. And there's 2 types of class 2 malocclusions. We're first going to talk about the division 1 malocclusion. And that's when you have that kind of overbite where the upper teeth, you can see a gap basically between the upper teeth and the lower teeth. And this is also usually accompanied by, when you look at the side of the face in the profile, a convex profile. So it kind of goes out, kind of like rounded like that. And if you were to look at an x-ray of the side of the face, you can really see how the upper teeth are and the upper jaw is ahead of the lower jaw. So usually the underlying cause of these kind of malocclusions is not that the upper jaw is too far forward. Usually the upper jaw, the bony aspect of it, is in the right position. It's that the lower jaw is retrusive, or it's too far back or not long enough. So usually the problem doesn't lie in the upper jaw, it lies in the lower jaw. And this is going to become important when we talk about treatment options in terms of correcting these class 2 division 1 malocclusions. So the second set of class 2 malocclusions, called division 2, is when you see all these teeth in the back, they are in that same position, kind of ahead of where they should be, but instead of seeing the gap between the front teeth on the top and the front teeth on the bottom, the front teeth are sort of tipped backwards, and so they're still like fitting tightly in front of the lower teeth, but because of that, the 2 lateral incisors are kind of edged out and flared forward, and so this is kind of a phenotype that you'll see recur a lot. And so the third type of malocclusion is called a class 3, and that's what we refer to as an underbite, which is when the lower teeth and lower jaw are ahead of the upper teeth and the upper jaw. So here's an example of a patient with a class 3 malocclusion. When you look at the profile, instead of seeing that rounded convex as in the class 2, in this case you see kind of dished in or concave facial profile. And in these malocclusions, funnily enough, it's not usually that the upper jaw is too far forward, it's that the lower jaw is too far forward, it's that the upper jaw is too far back. It's just not as well developed as the lower jaw. So from what I have seen, mouth breathing, improper swallowing pattern, and or improper resting tongue posture is contributory in the development of every type of these malocclusions that I just saw. And so that is why what you are learning about doing is incredibly important, because the way one holds their mouth and the way the muscles inside and outside the mouth function is incredibly important to how the jaws develop. And kind of the sooner one realizes that there's a problem and starts fixing them, the easier it is to kind of redirect any sort of adverse growth, and kind of make the orthodontic process easier and more predictable and more successful. So now we're going to talk a little bit about how we fix these malocclusions. And the first thing we're going to talk about is expanders. So an expander is used when the upper jaw is not wide enough. And so before, when we were talking about cross bites, when the upper teeth were sitting inside the lower teeth, that's an indication to use an expander. So, the other reason, there's a couple of reasons why having a narrow upper jaw is not ideal. So one is, yes, that you can have a crossbite. Two is that when it's too narrow, usually there's not enough room for the permanent teeth to all erupt eventually. Because when you have kind of a narrow circle, there's less space than when you have a wider circle. And so also the upper jaw dictates, and the upper teeth dictate how the lower teeth come in. So a lot of the time, if the upper jaw is narrow, then it kind of makes the lower jaw kind of always wants to follow the upper jaw. So the lower jaw oftentimes is narrow as well, and that can lead to a lot of crowding, as in this patient. So we use expanders to make more room for all the permanent teeth to erupt, to fix any crossbites, and most importantly, for you, to have a good home for the tongue to rest on. So if the palate is really narrow, it's harder for the tongue to learn to sit up on the palate and swallow properly. And I know you'll go into a lot of detail with this, so that's another main indication for an expander, is to kind of make sure there's enough space for the tongue. So ideally, the ideal timing for an expander is around age 8 years old, because the bones in the head tend to mature early. And so what we're actually doing when we expand is changing the shape of the bone. So we have to do that before puberty, because once puberty hits, the bones aren't as moldable. And kind of once one hits later puberty and adulthood, we actually can't get any sort of bony expansion at all without surgery. So expanders have become very common because they do such great work and great change. A lot of orthodontists are using them. So this is something that you'll see quite often. So this is a kind of expander we use in our office. It's kind of a little spring that pushes apart. And here's an example of a lower expander. But this is kind of a more common type of expander that you'll see used. There's a little key that's involved, and the parent turns the key, and it expands little by little. So what happens when you expand? Here's a little rendition of what a palate looks like. So there's a suture, or kind of like a break in the bone where the two shelves have come together. And this suture is still open, and there's kind of a ligament joining these when a patient is young and kind of before the time of puberty. And here's that same suture. The suture, this palatal suture, also shares a suture, the exact same suture. Kind of you follow it up, and it goes right, it intersects right in the nasal cavity. And so the palate shares, it's the same bone as the floor of the nasal cavity. So the added bonus of expansion is that when you expand the palate, you are also expanding the nasal passages and causing less resistance to airflow. So when you expand, you're getting that kind of break in the suture. Expanding the bone, and hence, so after the ligament is expanded, bone fills in, and that's where we get the stability for the expansion. And so after the expansion is done, and usually most times the expanders are in for anywhere from 6 to 12 months, depending on the office, patients are given a retainer. Sometimes it's a retainer that's fixed in the mouth. This is an example of one called a Nance. It's when there's bands that are kind of fitted around the 6-year molars, glued in. It's a little button that sits up on the palate. And this is a Hawley retainer. It's a removable retainer that they usually wear at night. Some practices have them wearing it all the time. And so these are the kind of things, like usually in our practice, we'll send the patient to have a myofunctional evaluation after the expanders come out. And so the patient might present to you having one of these types of retainers, and so that just so that you're familiar with what they have in their mouth. This is 2 possibilities. So now we're going to talk about treatment modalities for a class 2, or that overbite relationship. So there are tons of different ways to treat a class 2. There are many different products. Some come in and out of the mouth. Some are fixed in the mouth. Every single orthodontist you talk to uses something different. So, take 5 hours to go through all of them. So I'm just going to review a couple that I've used and that I think are pretty common. And this is one called a twin block. And this is an example of a removable appliance, one that comes in and out of the mouth. And this is most commonly used in a child. So someone who's anywhere from like 7 to 10 years old. And so the reason I like this appliance is, as I mentioned before, this class 2 overbite's usually due to the fact that the lower jaw is too far back, not that the upper jaw is too far forward. So what this appliance does is it helps position the lower jaw in a more forward position. Well, it doesn't really do anything to the upper jaw. So it's really just pinpointing the area of issue. And a child will usually wear this all the time for about a year, and then the thought is that the muscles get into the habit of having a lower jaw in that position, and it's stable. So this is a great appliance for early class 2 correction. So here's an example of an appliance that's used for later class 2 correction, something called a Herbst appliance. It's pretty common. It's glued in, it's glued to the 6-year molars, and what it does is it basically just forces the lower jaw forward. It sounds really barbaric, but kids are very adaptable and can get used to really anything. And we've had great success with this. Basically, just puts the lower jaw into a more forward position, and it's left in for about a year. Sometimes braces are added at the same time, and the muscles sort of adapt to having the lower jaw into this new position, and so it tends to be very stable, a stable correction as well. But this can only be done in a growing person. It's very hard to achieve success with this kind of appliance in an adult. So now we're going to talk a little bit about class 3 treatment, which is that underbite treatment, which is when the lower front teeth are sitting out in front of the upper front teeth. And so, as I mentioned in that case, usually the issue is that the upper jaw is too far back. So our goal is to kind of nudge the upper jaw forward. And the way we do that is we use an expander. And to the expander, we hook these little rubber bands and this headgear that kind of exerts a force on just the upper jaw to pull it forward. And so this is a very common treatment protocol for young kids. This does not work once a kid hits puberty. This picture is kind of a stock photo that was sort of deceiving, but usually we don't use this in a teenager. This is really most predictably used in someone who's like 7 to 9 years old, or even younger than 7. So once someone kind of hits puberty and hits that period of time, there's not much we can do to bring the upper jaw forward. We can really only camouflage the skeletal correction using, sometimes orthodontists will take out teeth, and then the other option is to do a surgical correction, but we're not going to go into that today. Just wanted you to be aware of kind of the treatment protocols. So I'm sure everyone is familiar with braces. I'm sure you'll have a lot of referrals, patients who are in braces. Just wanted to show you one thing so that if you see this, you kind of know what it is. It's something called an anterior bite turbo, and this is what we use to correct that vertical overbite, which is when the upper teeth were overlapping the lower teeth all the way. What these bite turbos do is act as sort of a stop so that when the upper teeth bite down, the lower teeth will hit against these and make it so that the upper teeth are not banging on the lower braces. And so this kind of helps us to correct the overbite. So that's what these are. So I just wanted to review quickly the typical referrals that you will potentially get from an orthodontist. So most orthodontists see kids starting around age 7, 7.5. And if a child who's that age presents with narrow jaws, an underbite, a severe overbite, phase 1 treatment is indicated. And that will be kind of carried out. Most of the time that lasts about a year. And then after that, at least at our practice, that's when we kind of refer patients for their first myofunctional evaluation. And so you'll see patients coming in whatever retainer they were given from the first phase. And the goal here is to kind of say, okay, we've made a good house for the tongue by widening the palate, or we've brought the lower jaw forward to a more ideal position. We want to keep everything kind of growing and moving in the right direction. We need your help to get the tongue in the right spot, get the swallow on point, close down the, promote nasal breathing, stop the mouth breathing. Like, it becomes very important during this period of time to do that, because the child is growing and developing so quickly and about to hit puberty that we really need growth to be on our side. So that's referral type number 1. Referral type number 2 is, if no myofunctional issues were evident, or we've just been monitoring a patient for more minor treatment, like they didn't need a first phase of treatment, and they start full treatment, which is when all the prominent teeth have come in. So maybe they're 12, 13 years old, and they go into braces or Invisalign. And after the teeth are straight and bite's kind of looking good, I start to notice the tongue peeking through, or I can't close down the bite all the way, or there's something kind of going wacky. That's when I'll refer to the myofunctional therapist. And that's sort of to help finish the case and kind of get things to a point where things are looking good enough to take the braces off, and then also so that I know that the case is going to be stable. So sometimes even if a case is looking pretty good, but I have a feeling that the person may have something going on, I'll refer to the myofunctional therapist just to kind of cover my bases so that we don't take off the braces and have things shift around. Because the referral type number 3 is when we have finished something and nothing's been picked up, or it's some sort of very subtle type issue, or for whatever reason, the teeth have shifted or the bite has opened up, and basically just a treatment is relapsed, which no one is happy in the situation. But the myofunctional therapist can be incredibly helpful in making sure that whatever retreatment is needed is not needed again in the future. So that's referral type number 3. So here are just a couple of examples of cases that proved not to be so stable. So this is one of our patients who finished up braces and came back a couple of years later and was in a complete posterior crossbite and underbite. And so you can even kind of see his tongue like peeking through here. This was a while ago, this case, but unfortunately this patient needed surgical correction after this. So, again, the tongue can do all sorts of untoward things. So that's relapse case number 1. This is another relapse case. After 6 months, she came back. It opened up an open bite. So even really subtle tongue thrusts can cause a lot of damage. So this is after only 3 months, the bite shifted a considerable amount. So basically, this is why I feel that myofunctional therapy really needs to be a big part of orthodontic treatment, because treatment kind of, in my opinion, extends beyond just let's set up the teeth and take our final pictures and move on. And we really want to keep the teeth where they are, because that's the patient's counting on us to make sure that they get the best result possible and the most stable result possible. So I kind of wanted to end with giving you a little bit of some kind of networking and businessy kind of ideas as you're getting started with this. So I think what's really important is the communication you have with the dentists that you're going to be working with. So I think it's great to kind of start the conversation with them once you kind of see one of their patients, and especially if it's not one that they refer to directly, maybe the patient has come to you through their school or from a friend referral or whatever it may be, just to open up the lines of communication so that you can start collaborating together and kind of letting the dentist know what it is you do, because dentists most of them do not really know what a myofunctional therapist is or what you do, what you're capable of. So I think just kind of getting your foot in the door by sending a really comprehensive initial report and then following up with an email directly to the doctor, like, hey, I saw so-and-so today and they're doing great and we're working on X. I think that can really kind of just start off the relationship. And then once you have that relationship, you can always offer a lunch and learn. That's great, especially to educate the staff and kind of let the doctor's staff know what you do. I think that's a really good way to kind of put a face to a name for you and go in and kind of tell them more about what you do. And it's great to show your own before and after pictures. That's always, having a visual is always very beneficial. And so another idea is there are a few Facebook groups that I know of for dental professionals and myofunctional therapists kind of to collaborate. And I see a lot of posts. There's one called the Oral Myofunctional Facebook group, I think it's called, but a lot of times a dentist or an orthodontist will post, hey, I'm looking for a myofunctional therapist in whatever town. And I think if you're on those groups, you can chime in and say, hey, I am one of those. So you can kind of look for like-minded professionals in your area by connecting online. So, oops. Anyway, thank you very much for your attention. I welcome any questions. This is my personal email, so feel free to email me. And I look forward to hearing from you and wish you the best of luck with this endeavor. Thank you very much.